Hi, everyone. TJ Ald's I-45 now in Galveston now. Thanks for watching. We're glad to have everyone on board with us for another edition of UTMB Healthcare's Unmasked, and we're glad to have a great team in here with today. There's an interesting subject. Just imagine if you had a check engine light on your body. Well, you don't. But how do you find out what's wrong without going through a battery of tests? Well, our next guests are going to be able to tell us all about that and more of this groundbreaking technology that's coming through the UTMB Health Diagnostic Team. We'll talk more about that right after these words from UTMB Health.
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com.
And welcome back to the show, folks. As I told you when we started off with this, there's always been this talk about, hey, how do I find out what's wrong with me without going through 100 tests at any given time? And there's some groundbreaking research that's being done here, and creating that with it is the new diagnostic team at UTMB Health. And what does that mean? Well, we're going to find out. And thankfully, what we have here to help us with that is Dr. Michael Laposata, who's here with us here, and then the director of that lab, JuanDavid Garcia. Thank y'all both for being on with us today. So, Dr. Laposata, let me start with you on this, because when even I got the first indication of what we're going to talk about here, I was like, so what does this do? And when Becky Ubbenhagen was telling me about this, I said, and after she kind of explained it for a while, I said, I used that check engine light thing. I said, okay, so this is like when I get my car, it goes check engine light. I go in, they plug it into a computer and do so. It's not that simple in this deal, but in many ways, it is when you're not feeling well and you've done with your primary care doctor a couple of tests of, oh, maybe this, maybe that, and then it still comes back negative. What you're proposing and trying to create here is a way then to narrow down through a blood test of what may be wrong with somebody. So folks are going to hear that and go, what? How does that work? So once you explain to us what this concept is.
Yes. So the engine light is a great example, because you feel something and you're not normal. You need attention. So the question is, will your doctor figure this out? Is this something he or she has seen a bunch of times? Well, back when I was a resident, we had about maybe a couple of hundred blood tests, and every doctor pretty much knew what those results meant, and they know which test to order. But what changed over time is now we have all kinds of tests, including genetic tests, DNA kind of tests. And these are now something that most doctors need somebody to help them with. Pick the right test and say what the test result means. So we've been working on this concept really for a long time. The original idea popped up in the mid 1980s when I realized as a resident that my fellow doctors didn't know how to interpret tests for blood clotting. And I said, what are you doing? They said, we're transfusing blood. I said, we have an epidemic. The blood is contaminated with this virus that produces the disease we call AIDS. You just don't give blood. You have to figure out what the tests mean. Mm-hmm. So that really evolved from 1984 until I fortunately came here in 2014 and met Juan Garcia and a number of others. And we created this group, which we now call a diagnostic center. And the plan is that nobody should wait a long time for a diagnosis. If your doctor doesn't know what it is, then you have the doctor press a button that says, I'm referring you to the diagnostic center. Maybe they're only partially sure about what it is, or maybe they have no idea. But we are creating expert teams to deal with certain diseases, and we plan to link throughout the country to experts wherever they are for even the rare diseases. Gotcha. That's the plan.
So, JuanDavid, let me ask you then on that part of that, because when that button gets pushed, then that's going to come over to the lab when you've now got to figure out what to do. Now, I was thinking, is it as simple as coming in, getting some blood drawn, and then you go from there? How does it work from that standpoint?
Yeah, no. So I think that the order, as Dr. Laposata was saying, I created this, and the main idea is to have a support for the other clinicians on that. Yeah, sometimes I personally think that we are very unrealistic with all the responsibility that the PCPs they have, because they need to know about everything. And the idea is just to let us help you with, especially with the laboratory portion on that. So that's what we are trying to do. I mean, with the help of Dr. Laposata and other expertise on that. It would be having that, creating that request for that special consultation. And at that point, it would be looking at the test or suggesting any additional testing or suggesting any replacement for that type of test. Then communicating with the patient. The patient will go and have a lab draw. Most of the time, it will be a blood test. But there are multiple other sources that we can just have those tests to be analyzed. But what is very important about this, as Dr. Laposata was saying, it will be the interpretation that will be guiding and helping and assisting the physicians and the patients
Right.
on that as well.
And Dr. Laposata, as I'd asked you, we do our pre-meeting on this, was that, okay, this is not like you take a blood test, you get up and you can pinpoint what's wrong.
No.
This is, you're based on data that's available.
Correct.
You're at a higher risk of this or the risk of this. That allows you to kind of hone in on a situation.
Yeah,
Right.
that's a great example. I can tell you something that is in everybody's mind. Pancreatic cancer is maybe the most frightening diagnosis anybody could get. It's 90 days from the diagnosis until death. And that's average across America.
And we should point that out. The reason for that is by the time anyone catches that, it's too late. You've already shown symptoms and everything else. It has already grown, and then
exactly.
At that point. And
so it takes 4 years. We have learned 4 years from the time you get your first cancer cell until you get something that tells you you're sick. Yeah. So if something's growing for 4 years, maybe we could find it. Now, in the recent months, there's been another study that says you could have an MRI of your abdomen, and that would pick up masses. Well, the pancreas is in the abdomen. But would you want to do an MRI of everybody? Well, it turns out if we do your genetic study, even before you're sick, we could find out if you're predisposed to pancreatic cancer. Let's say that you have a risk that's 7 times normal for pancreatic cancer. Those are the people that should have their abdomen screened every month, sort of like a colonoscopy. You don't want to do it for everybody because a lot of radiation may not be good for you. But if it's pancreatic cancer and a high risk, perfect way to identify the person. And that's really a diagnostic challenge.
Right.
This isn't a treatment challenge. This is focused completely on, do you have this?
Right. And I'm going to go back with the car example that I brought up before. And because one of the things I do when I bring in my truck for an oil change at my buddy's Cook Ford down in Texas City, the one thing I always do too is, hey, while I'm here, check everything else out too, just so we know.
Yes.
I got time, check it out. They'll do everything. They hook up the computer and do that. So in this way, this is kind of a two-way approach to this, because eventually, and again, I know we're in the infancy of this, but as you look at this down the line, it could be a setup where the patient says, you know what, I'm going to go in for my annual physical, and while I'm at it, I'm going to get a diagnostic.
Yep.
And that's done. And then when you're meeting with or you're going in for your annual physical with your primary care doctor, the primary care doctor says, "Oh, let's go ahead and have a diagnostic for you. It's been we've done this, but you're at this age now. We want to screen for this." JuanDavid, is that kind of how it could work?
Sure. Yeah. The one of Dr. Laposata is bringing a great example about that pancreatic cancer, and that's something that is very dear to my heart, because that was exactly what happened to my dad. As Dr. Laposata was saying, since the moment that we were able to diagnose, it was only 3 months. And that has been, on my personal side, a lot of the incentive to work on the program and to work on all of this. I'm 100% sure that if the program would existed when my father was alive, we could have done something sooner. So the idea was based on the genetic predisposition and the list of the mutations. We will know that the patient will be at risk, and then we can focus in recommending what type of test would be useful to make sure that the patient will not get to that point on developing. When the cancer is starting, There are some research tests that they are still developing, or other type of tests that could have an indication, hey, this test is going up, but you have a genetic predisposition. We should start being a little bit more aggressive and looking into that, to what Dr. Laposata was saying, do an MRI, and detecting that cancer earlier will be the difference between life and death.
I mean, pancreatic cancer is a great example
Yeah.
of something. If you're able to catch the cancer cells early,
Huge.
that's a game changer.
Game changer.
Game changer. Because what we know now is that once you've been diagnosed, there is no cure for it.
Too late. It's everywhere.
But what we don't know is if we're able to catch something early, could it be treated and then make it a survivable
surgically removed? I got the whole thing. And then we have people who not just do blood tests, but they look at biopsies. So if somebody cut out a pancreatic cancer from the pancreas, we look at it and make sure that they got all of it. All the margins are clean. There's normal cells all around this thing. So we have the benefit of that diagnostic piece. So really, this is a combination of the blood tests, the people who look at the biopsies, the people who look at all the imaging studies. And this diagnosis part of medicine really was left in the hands of all the treating physicians who see the patient face to face. And as it got more complex, we're realizing you have to build an entire area of specialty around getting the diagnosis quickly.
Right. And the other part of it is I use an example of this when you're telling me about some years back. I had an episode where I had my blood pressure was super high, some stuff, and I went into the ER at the recommendation. I was at my primary care doctor's office. She said, let's send you to the ER. And so the ER physician says, listen, I'd like to run some tests. I think it's this. I don't know. He says, and then he says, and he started to check off all these tests, telling me what he wanted to have done. And I said, well, wait a second. How long is that going to take? He says, well, you can, probably, you have to get it scheduled up because different people do different things and everything else. And he said, or we can just check you into the hospital and we'll do it all within like 48 hours. And I said, well, I'm taking the hospital check-in part so I can have those tests done in 48 hours. A little bit different there. In this case, it's taking out even that deal. You can narrow down what tests you have to do. Is that right?
Yes.
I mean, that's the way to do it.
For your example, TJ, I think it's important to know that there are now tests that tell us which antihypertensive drug you're going to respond to.
Right.
So the very first thing you want to do, even before you ever get sick, I had it done, Juan had it done, is a test for something we call pharmacogenomics, which is how your drugs relate to your genes. So what we would do for you with your hypertension, assuming you had the pharmacogenomics profile, is your doctor would look at it and say, what? He's not going to respond to those 3 antihypertensives. I'll pick this one because I already know that's going to work. That at least gets you treated immediately.
Right.
And then we could figure out if it's associated with your thyroid or something else. But the idea is to get your blood pressure from whatever it was into the safe zone with the right drug. And this pertains to drug-gene interactions for depression, hypertension, antiplatelet drugs like after a heart attack. So 1 out of 7 people don't respond to Plavix.
Right.
So we have to know that for all the patients.
That's the part when we talked earlier that I want to drill in on when we come back, because just the part of being able to know what medicines are best for you here. I know there are patients out there who have said, I keep going back to the doctor because this is working, but it's not working. And then they have to adjust the doses and everything else because every individual is different.
Everybody.
And if you can lose that genetic profile from that. And so we're going to be coming back here in just a little bit. Trust me, folks, this is newer stuff, and we're going to address a lot of that here coming up after these words from UTMB Health.
UTMB knows when you're expecting, you may not know exactly what to expect. From that first embrace to all the milestones that follow, we know how important each stage of life is. That's why UTMB Health's obstetrics and gynecology physicians specialize in innovative women's healthcare through all phases of life. UTMB knows women's health. UTMB knows you. To find an OBGYN specialist near you, visit utmbhealth.com/women's.
And welcome back to Healthcare Unmasked, presented by UTMB Health here on I-45 now and Galveston now. And Dr. Laposata, this is just this is the part that just wowed me. And I think I can relate to this, like in a lot of people. You just mentioned about the hypertension meds that I have my nephrologist who worries about certain parts of the hypertension affecting the kidney disease.
Yes.
I have my primary care doctor who's also worried about that, but other ailments. I have Dr. Janine, who's worried about how it's going to affect my heart. And they're all going to want to have different things looked at any given time. And they're all going to think about, well, I think this medicine may work or this medicine. Well, let's check here. And the three of them have to all go and talk and figure it out. And then even then, I don't want to say it's guesswork, but it is percentage work. Well, he's this, and this. And we know this is the part where this type of testing could come in handy right away, which is not as many going back and forth and trying to basically get the right balance of meds. This can kind of pinpoint and say, hey, if you do this, it'll work more effectively. If you do this pill, not as effective. And that's the exciting part. Explain how that would work.
Yes. So I think that the plan, and this is really attributable to Juan's success here in interacting with a group that will put this on our iPhones. We hope to have an app, and we're building it with a company so that you can click on to a button that says pharmacogenomics. And when you go into your doctor's appointment and you have an infection, you will be able to say, wait a minute, just a second, I don't respond to that antibiotic. Or somebody has a heart attack and you say, I'm sorry, I'm one of those 7 people that can't take Plavix. And what we have done that is the secret sauce to all this is that pharmacogenomics has been around for a while, but what they give the doctor is sophisticated genetic information. And most doctors really don't have time to sort through that DNA code, A, T, C, G, to figure out what drug do I give now? How do I adjust the dose? So what we did was we created with a person who's an expert. His name is Bradley Grant. He's a doctor and a lawyer. And Brad was able to take all of these complex genetic results and turn it into something that every doctor could understand. So can I give you a personal example?
Sure.
Okay. So I played baseball for a long time till I was 19. I was a catcher. I took a few blows behind home plate when the runners came charging in from third base. And sure enough, as an adult, I got back pain. So what do you give for back pain? Well, one of the things would be a non-steroidal anti-inflammatory drug like ibuprofen.
Right.
So I got ibuprofen. Little did I know that my genes don't accept ibuprofen. So when I was taking ibuprofen over the counter, meaning nobody gave me the prescription, I would take the dose and then the highest end of the dose. What I noticed as I started one of my courses of therapy because of back pain is my kidney function started to go down. There's a test called GFR. Mm-hmm. And I said, what's that about? At which point I realized I needed pharmacogenomics because they discovered a new drug-gene interaction between ibuprofen and genes. So I did it, and I have the mutation. We all have at least 7, that's the average, 7 mutations in these genes that metabolize drugs. And we're going to come into contact with drugs, at least 3 to 5 in our life, that just don't work.
Right.
Well, so I lost a quarter of my renal function, but I figured it out and said, oh my goodness, I haven't taken an ibuprofen tablet since. So I take acetaminophen for pain, but I get the adverse effects, but I don't get the benefit. Right. And I could have known that ahead of time, and it would have helped me down the road.
And see, and that's the thing, because as I know with my kidney functions too, you can't take ibuprofen for it, but you find out the hard way about it. For another thing is like on my chart it says, are you allergic to certain meds? And so when they check my chart, it says, don't give morphine, for example. But I found out the hard way. Morphine makes me ill and I have an allergic reaction and sensitivity to it. But that's not the way you really want to find out. So JuanDavid, this is so exciting because that alone, I mean, let's just talk. I mean, we're going to talk about other things, but that alone would be another huge game changer if people know what meds are out there that will interact with them. And I would think it would help on the research side of things too when they're developing these drugs.
Yeah, and the only thing that is a very important point of what Dr. Laposata was saying is he got this medicine out of counter, right?
Right, over the counter, yeah.
It was not prescribed for any physician. So is out of the loop on that. But what we're trying to do is developing this app where we can empower patients to say, I want to have this test done, and I will understand it. The interpretation of the test will say very clear, you're going to take a high dose of this, you need to take this or replace it for this on that. And at the same time, it's going to be information from the patient to the clinician to say, I did this test and this is what I'm telling. And it will be a very valuable information for the physician when need to prescribe something that it will have some kind of interaction.
Right. And understanding what it means is the
It is
important
the
part,
key.
right?
That's the key thing.
Why I love my chart and all, it'll send me my test results. And I go through it and I go, the first time I go, what the heck is this?
Green is good.
Yeah. The color scheme is the only reason I under certain things. But then I wait for the note to come from Dr. Sonia Sood. I got to give her plugs. That's my primary care doctor. And she always does a great follow-up with, okay, here's what this means. Here's what this means. If you watch this and everything. Okay, that's the only way I learned how to really, really work. I mean, the green and yellow and red, okay, I get it. But still, I would rather,
it's confusing.
I'd rather like, okay, what's this number really mean and stuff like that, and then hear it. And again, this goes to the other part was you really need to communicate with your primary care doctor. And this is one way is because one of the challenges is going to be is that when this does come online, that you're going to have to know as a patient, you can ask for it.
Yes.
And the primary care doctor has to know, here's another tool.
Yes.
Because there's no knock on this. It's just medicine changes so much that there are some doctors that are always checking everything.
Yes.
And they go to seminars and everything else. But I know this from talking to Dr. Janet, our cardiologist here, who says, it'll be one day this, and then 2 weeks later we have something new.
Absolutely.
And he keeps up with it because he's always giving speeches. So,
right.
But he says, cardiologists on a daily basis are not doing that.
No.
And so this could be a wonderful tool, but the matter is, I would take it, Dr. Laposata, is to make sure that it becomes part of the fabric of healthcare.
Absolutely. And what's written in the news today is how do we get pharmacogenomics to everybody?
Right.
Let me tell you that this is a test we can do now. We are only 2.5 months in to the establishment of this project. We're building the infrastructure. It's coming along quickly. And our first product is pharmacogenomic testing, meaning whether you give us a blood sample or a cheek scrape, we will be able to look at all the mutations you have and give you a picture, and it'll be a printout till we get the app built. But you will be able to say, oh, there it is. That's my printout. I can take this drug, but not this drug. So we're going to be adding on areas of testing. Pharmacogenomics is first. We're going to look for a whole bunch of other things. We have very well developed bleeding disorders, clotting disorders, autoimmunity testing. So we will pull in each of these as time goes on, and we'll be able to have an array of things we can test for, both preventive, as you pointed out, and when you get sick from it.
Right.
So that's the idea.
And you provided here, I'm going to bring up on the screen now to take a look to it, is these screens, and forgive the artwork. I did not draw these, folks.
I did.
That's the stick figures.
That's
here
as good as I could
on
get
there.
Yeah.
So look at this passive clinical laboratory that I have up on. You can see it on my screen here. You won't be seeing it here, but if you refer to your sheet there, what are we looking at here?
Sure.
We have and I think that's a wall. It's not a chimney, folks.
No, that's a wall.
When he first brought it up, I thought, hey, Christmas season, that's a chimney. So, but explain this to me. You have the ordering doctors of the diagnostic doctors, and there's a piece of a puzzle. Explain what we're looking at here to kind of give folks an idea.
So pathologists have been around for a long time, and the pathologists largely look through a microscope and give you the results of a biopsy. Do you have lung cancer or not? However, the pathologists are also responsible for making sure that the lab tests are done correctly. And you buy the instruments, you train the technologists. And so that's a very passive thing, because what we do is generate results, which are often really complex now, and throw them over the wall to some primary care doctor. And we say, your patient has factor V Leiden mutation and they're heterozygous. And the doctor says, so what do I do now? Does that mean I give her blood thinner? And
Right.
for how long? So you see the puzzle pieces falling down by the foot of the doctor who's ordering doctor is the one you see face to face, right?
Right.
And we can't have that. So what was apparent to us is that pathologists have to take on a very different role. That is, not only read things through the microscope, but we also have to take all these laboratory tests for everything. And we have to put the puzzle pieces together. And we have to say to the doctor, you know what? This is rheumatoid arthritis. It's not lupus. And here's why.
Gotcha. And then you get into so this is what you've been talking about here but this does in many ways allow your primary care to spend more time.
No question.
Checking on you. Is that all right, JuanDavid?
Yeah, definitely. That's the purpose of this is to be a multifunctional. It's just for the benefit of the patient to have everybody together taking care of the patient. And what we're trying to do here is just to help with that little piece on the lab interpretation, on the test interpretation that is going to be very, very useful for the patients, definitely.
Right. And if you're looking at the chart, Dr. Laposata, we're going to hang this up at the Louvre, I think, for your great artwork. I'm just giving you a hard time. But if you notice the subtleness of this is good, that on the conferring diagnostic doctors, they're holding all pieces of the puzzle now.
Here we are.
Whereas before they were separated out. They were 3 underneath the doctor, 1 sent on over. But now they have all 4 of the pieces with that approach. But the biggest part of that comes into now the wall's down.
The wall's down.
And the puzzle's there.
Yep.
I mean, this is actually a great example
Yeah.
of how this would work. You've taken down the wall. And I've got to tell you, ever since we had Dr. Reiser on with us on his first day on the job, we should point out that he has talked about the biggest thing that has to happen in healthcare is tearing down silos.
Yes.
Whether we call it walls or we call it silos here, this could do that now.
Yes.
Is that it becomes a continuum of care where there's a whole team and the primary care doctor is not the one that has to interpret every little thing that comes their way. And they may know it, but that they now have their conferring with the diagnostic doctors to come back and say, let's look at this, and this, and this is here's our next steps. Is that kind of how you envision it?
Absolutely. I mean, think about the games, the sports games, football, baseball, where you do a replay, right?
Mm-hmm.
And you get an expert. So what this means is the doctor makes a call on the field, so to speak. They see you and they think, well, it might be pneumonia. And I think it might be this particular bug because that's a common thing to cause pneumonia. But they can also then call in the people to review it who are the experts and say, hold on, this may be pneumonia, but it's from this pathogen, this bug that's causing it. And therefore you need this antibiotic. And we take the pharmacogenomics results and say the patient can respond to that. And all these diagnostic pieces come together for you in real time, I might add. This is not the case where you're talking about something where you waited a year to get a diagnosis.
Yeah. When we come back, we're going to dive down in this a little bit and how this can become a national effort starting right here on the island at UTMB Health. And we'll do that right after these words from UTMB Health.
UTMB Health knows that when you need advanced surgical care, you want a specialist who's an expert in their field. Our surgeons provide innovative and advanced treatment options for adults and children, for neurosurgery, GI, heart surgery, ENT, urology, and more. UTMB knows surgical care. UTMB knows you. To find a UTMB Health specialist near you, visit utmbhealth.com. UTMB knows when you're expecting, you may not know exactly what to expect. From that first embrace to all the milestones that follow, we know how important each stage of life is. That's why UTMB Health's obstetrics and gynecology physicians specialize in innovative women's health care through all phases of life. UTMB knows women's health. UTMB knows you. To find an OBGYN specialist near you, visit utmbhealth.com/women's.
Welcome back to UTMB Health's Healthcare Unmasked. I'm TJ Alt. And we have been talking about an exciting, I know I say this every show, folks, but it is. I'm one of those, I absorb the learning that we can get from this show every month. But, as we talk about this diagnostic, approach, the diagnostic team. And, I use this comparison. I know I've used the car, but the other one is that, anyone who was a Star Trek fan will remember your Dr. McCoy would always take his little thing and just go over this little thing where I scan the whole body. We're not there yet, but this is kind of a baby step, I would think, to that. But to get to 2.5 months now, y'all have been working on this, but to just get started, that takes money. And so it's like, okay, because everything you're talking about here is, yes, it sounds like common sense to me, but maybe not in practicality. But so that takes funding to figure out how to go. And you had some folks really step up and help out with that.
So that's true. We were fortunate to have interacted with some influential people from the Seeley Smith Foundation. And when they saw it at a personal level, they, gracious people that they are, said everybody should have this. There's really nothing that would stop it from happening. You have the expertise. I said we need the funding. They gave us grant money, and we were able to start with a substantial sum that will continue over a period of 3 years. The goal is to make this revenue generating enough that at the end of 3 years, we have enough funds to keep going what we built over the first 3 years. We're confident, and I will say that Juan is the leader in figuring out how all of this financial arrangement comes together so that we have services that everybody needs, the services grow, and that we have enough people who can do the interpretive work. So yes, we're 10 weeks in, but I will say, we've been thinking about this, some of us, since 1984. And it had a trial at the University of Pennsylvania for years, 85 to 89. It had a trial where we actually implemented such a team, an expert team for coagulation, bleeding, and clotting only. And that was 18 years. And then Vanderbilt, 6 years, where we had 5 different teams, one for leukemia and lymphoma, another one for coagulation, and several others. And now we get to UTMB. And we have the benefit of the Seeley Smith Foundation, who has encouraged us to do this and made it possible. And we've already built about 8 of these teams. So it's just a matter of bringing them online. So we think that the first 7 or 8 will come relatively quickly, so that if we are now 10 weeks in, by the end of this year, that is, we started in September of 23, maybe by September of 24, we'll have 7, 8, 9, 10. But the goal is to cover all the different things.
Right. But you do have to start one place and then go to the other, right?
And another important point is we definitely are very blessed and very thankful with the support that we have been receiving to create this, because it takes time and effort, as you mentioned. But the idea is we want to have the patients from UTMB benefiting from this first, but in our mind and our goal is how we can make this available to everyone. We are thinking how we can give access to national and even international with the different programs that we can develop with this. So I think that that's something very important. As Dr. Laposata was saying, it has been many years on trying to get to this point, and now having the support definitely is a huge help that we're trying to do.
Right, because this is would be unique to go, because it would be the only in the country.
Only one.
On that. It's been tried and kind of fits and starts along there. And I would take that when, the question is asked, well, why aren't other folks doing this? It does take the money. It does take the dedication of not only the staff, but it also takes that money to come in. It is in many ways like the research and development is in a pharmaceutical company, that this is so different. It could break the culture all along the lines. And with the implementation of AI, for example, I would think it would help on some of this as well.
Enormous.
And in a way, I kind of looked at this as kind of a physical AI, because you can, you'll have the data, and as more people go through the diagnostic, you also have even more data there.
Yes.
So that's why I compared to AI is that it's gathering more data to kind of hone it in. And I mentioned this. My wife was very fascinated when I talked to her about this last night. And one of the things I brought up to her, I said, I kind of understand it better now, is that every few months or so, I get we're part of Ancestry.com. You know,
Yes.
we did the whole DNA test,
yes,
right?
Yes.
So every few months, we get this updated chart say, okay, we're now able to hone in more of how much Scottish you are, or how much from Wales you may be, or how much from Sahara Africa, or something like that. And I kind of, and I don't know if I'm going down the right path
Yes,
here,
you are.
but
You
I
are.
think it is.
Yep.
As more data is available,
Yes.
then you're going to be able to pinpoint even more so as we go down the line.
Oh, let me give you another personal example. So it turns out that my son is getting married and he's engaged to a woman who has a rare disease. It's called phenylketonuria.
Mm-hmm.
So this woman knows she has the disease, but what we can tell her is what exact mutation there is in the gene that causes this disease, phenylalanine hydroxylase. And there are at least 45 different ways to break that gene or mutate it. It turns out if you have this mutation, then you could take a drug that will help offset it. Maybe you could eat a little protein. If you have this one, it's more severe. So we will be able to go all the way down using a system like Ancestry, 23andMe, but dig way deeper to not only say you have phenylketonuria, but we know the exact mutation. And that has a lot to do with how you treat it. You can see how personalized it gets.
Right.
Not only do we tell you, you have phenylketonuria. Oh, wait a minute. You have phenylketonuria and you have this mutation. So now, as new research comes out and they say, oh, we're doing this study on phenylketonuria, we could look at it and say, oh, that's on my mutation. That's what I can benefit from. So really, it's digging to the bottom of the ditch to be able to say diagnostically, this is what you have. And this program, it's a single gene disorder group, has a lot of artificial intelligence in it.
Right.
So we have a member of our group, a pathologist named Peter McCaffrey, and Peter is helping us connect Epic, where your results go in, to a whole bunch of comments that we're writing so that the computer can suggest a comment using artificial intelligence and say, that's the one. That's the thing that goes in the chart. So this way, where we could do it all by hand before, and it might take an hour, now we can do that in 3 minutes with greater certainty.
Right. And also, too, we should point out that this does not take out the direct checking.
Oh, no.
Of physicians
No.
and researchers and the like as well. I think because, the one thing I thought of in this, we saw Theranos is that kind of, that was going to be the catch-all, remember? I mean,
Right.
but it got so much attention for those, and people said, well, yeah, of course that wasn't going to work. They never did. But we're talking about something different. That was like telling you, they were bragging about something that didn't exist, of this one test will tell you everything. It really doesn't tell you everything when you do the testing and diagnostic. It tells you where to look better. And then it still takes the experts to come in, whether it's kidney disease, oncologists.
You got it.
That's still needed here. It's not taking out the human element and the expertise.
No,
At that, and that's where this differs from that approach from there greatly. I don't want to compare the two, but I think the general public will hear that and go, oh, wait a second, we've already seen this before.
Yeah.
And that would be and they have concerns about AI too.
Yeah,
so.
it's a very interesting what you talk about the Theranos, because we do have the opposite. They had an idea, but they didn't have the experts. We do have the experts, and now we have the idea, and we are making this. And we chat a lot. I mean, we were laughing about because we discussed the situation with Theranos before. But we really, what we are thinking here is just thinking on the future. And I love the vision that you have about the future and all of that, because eventually what is going to happen is many of these lab tests will be done at home, and patients will be doing that. Or it's going to be a better test and more specific. And what we're trying to do is just, the more that we can have the genetic data, that we can understand, that we can interpret that we can be more personalized medicine, and that we can be more proactive, the better outcome will be for the patients. And that's one of the purpose of the program, is just keep adding products that will help us with that personalized medicine, that the patients will have full control on that, and it will be part of the care of the treatment as well. So that's what we want in the healthcare system, that the patients participate actively in the treatment on that. So it's not going to be any decision. They will be part of that, and that's going to be a great tool.
And you're preaching to the choir when you hear about patients being at. I am so particular on that myself. I am amazed that someone will ask when they bring their, using the car example in, they'll ask way more questions about fixing the engine than going into a doctor and said, okay, when the doctor asks you how you're feeling, you need to get very detailed. You need to share everything. That's the one person you can with. But part of it is too, is to ask questions, to say, hey, what is this doing here? Okay, now what I got to do? Don't wait for the instructions to come. Be an active participant in this, to the point of saying at some point, we hope that you can order the diagnostic, either go into a clinic or get it at home, like you say, at that point. And then now you have some information that you can take.
Yes. Let me make, if I may, let me make a point about what you just said, TJ. And this relates to the patient playing a role in his or her care. The National Academy of Medicine in the United States is the most august body of doctors that exists. And they have work groups that they create to address major problems in U.S. healthcare. And in 2014, they created one on diagnostic mistakes. I mean, somebody has 10,000 tests that are available. Did you make a diagnostic error? Did you say that somebody who was short of breath had asthma, but they had a clot in their lung? So we wrote, I was a member of this 21-member panel, and we wrote a summary of our conclusions. And the first one is that the patient has to be more involved in his or her healthcare. Right. Another one is doctors should have a better sense of what they don't know. And I would say that a lot of doctors are willing to ask for a consult. I'm not sure of this. I'm kind of sure. But if it were easy to do the right thing, which is what we're trying to do, make it easy, just press this button, call this number, you get a bunch of experts who are happy to talk to you, not just the people who did the test, but the people who know what the tests mean. That, I think, is really the big difference here, and why UTMB and the Seeley Smith Foundation, who's so supportive of it, and the people in Galveston, is likely to see it all first.
Right. And your vision for this, though, and I know, Juan, we got into this the other day, but your vision for this is that this is not going to be within just UTMB how this works. It is, once you get that app going, and like that, you may be able, like, okay, we're looking at this particular ailment here, a higher percentage of, and the real expert on this is at Johns Hopkins. Now you want to have that expert within your field. Within is one of those kind of, I call it extra consult to come through. Obviously, you're not going to go hire that person and bring them down here.
Right.
Well, you may, but I'm just saying, if you don't have that expertise there, you're trying to broaden that where you can reach in anyone around the country. Now gets into the part we talked about, the finances of this. But JuanDavid, you and I talked about this the other day, is that now you got to figure out the financial model. Because while this is going to have its cost, it does skip the whole, let's just understand, the 10,000 tests. If you're not doing the 10,000 tests, you're not spending as much money in areas that were getting money before. But also, too, if you're going to tap into the expert of, say, someone in Chicago, Dr. Reiser, I hope you noticed I mentioned your last city, but that they're going to want to be compensated, too. And so that's one of the challenges you're working on right now, right?
Yeah, so definitely one of the things that we want with the program is, as Dr. Laposata was saying, is just to look at the experts. And there are some rare diseases in the lab medicine that they have expertise in the different places, and how we can engage, that expertise, because that's exactly what we want to do on that. So I was mentioning with you the other day something about, like, eventually, we need to start looking some type of situation like that Uber for physicians, where
Uber for physicians. I remember that now. Yes.
That expertise will be, I have expertise on porphyria, and we do have expertise here in the island. Is one of the a few centers in the world actually to do that, and we have many other expertise, and there are other places that they have that. But eventually in the healthcare, we need to get to that point when that collaboration will exist, because it will be for the benefit of the patient. And we have to go over those silos of, this person cannot provide an opinion on this case because he's no patient of this university, and so on. The future will take us there. We need to start now, and that's what we're doing. And you're absolutely right. It is a part of that. The other constraint, it is part of right now there are insurance that they probably don't pay for some of the genetic testing, which is very unfortunately, and that is a process. We need to show the value of those tests, and then the insurance company will say, yes, it is worth it for me, for this group or for this diagnosis center to tell me that this patient has a high risk for pancreatic cancer. They are monitoring with a specific lab test, and now it's getting to the point that preventively I can get to that point. The patient to pay for a very expensive treatment and to go to that point. So at the moment that we are able to prove to those companies to say it's worth it to have the investment on the program, on this type of testing, is a no-brainer, and they will say yes, they will make that accessible to everybody. Unfortunately, we are not at that point yet, but we are firm believers that the more data and more patients that we have here, we can have publications and we can show them the data to say this is worth it and this is a clear example. And in the meantime, we're going to be beneficiating people on you.
And that's one of the reasons we wanted to have this show. We are only 10 weeks in, because when David Bethay, who was working with you already on a lot of this and mentioned it as a show idea to Becky Ubbenhagen, and then came to me about it. It's like, I was, what is this? I'm trying to figure it out. And then more after talking with you guys the other day and then doing some research on this, I was like, oh my goodness, how this could change healthcare across this. Let's forget globe. Let's just talk about this state.
Yeah.
But it is going to take not just you two and whoever you bring in and doctors. It's going to take patients. The other is it's going to take elected officials, I think, too, to understand, listen, we probably could save a lot of money on Medicare, Medicaid, and what we're having to pick up on health insurance costs if we work on something that actually truly is a preventative test.
No question.
Because right now, a lot of tests get rejected because, you don't need that many tests. I mean, that's one thing I know. I hear it from insurance, and then folks are on the phone fighting with their insurance company. Listen, my doctor ordered this, but as this data goes, to be able to show, listen, we're talking about these tests that can narrow it in and lessen the number. That saves money. Preventative medicine is proved over and over and over again to be less expensive. But it seems sometimes it's hard to get the insurance companies to be convinced that's better than waiting till someone has to go in and have heart surgery.
Yeah.
And where it's too late.
You make an excellent point. I think people should realize how much it costs to stay in the hospital.
Yeah.
If you go into the hospital for a day, it's somewhere between $1,000 and $1,500. So if you could have a lab test, even if it costs $500,
right,
you're actually saving the money from being in the hospital for a day. Insurance companies have to realize the pharmacoeconomics of doing this testing, because it costs much more for chemotherapy and surgery for pancreatic cancer than it does to figure out how to remove the whole thing when it's still stage 1 and something you can take out completely. So we have to have data. We have another member of our group, Dr. Chris Zahner, who is really a lead on writing the papers. As we get data, we will be putting together papers that say, here's what we learned. These are the first 1,000 patients, and this is what we need to do. So all of this is going to show up in the medical literature to make the point of how valuable it is. And to your other point, throughout my whole career, I've wondered what was the most important thing I could do. And I will say that the thought of influencing almost every physician encounter with a patient is about the highest thing you could do, right? Everybody who goes to the doctor today, right? Who has heart disease or some known
problem. We're doing
problem.
it like it was done when it was
right. Why are we doing
ever.
it? And like it was 1900.
Yeah.
And really putting together this team with Juan and the people who were mentioned, Doctors Grant, Sonner, McCaffrey, and another one, Thacker, who does the biopsy evaluation. It's all digital and artificial intelligence. That group has now enabled all of this. And again, credit to UTMB, right? This was a place that was a fertile ground to recruit the best people.
True.
And somehow we did it. And not only that, we were intensely collaborative. I've been at other places, but I will tell you, none like this, where the collaborative spirit is great enough to generate something like this.
I wonder, though, too, if a lot of that comes from the fact that you're at an institution that prides itself as much on research
Yes.
and breaking ground
Yes.
on stuff as it does about just taking care of patients.
Correct.
And that's something that I brag about this all the time. It's folks, yes, UTMB sponsors this show, but also too, it's like the old men's hair club commercial. I'm not only the owner of the company, I'm also a patient, but I'm also tied with UTMB. As I say, there was a time that folks would have their doubts about what would happen here. That's changed. I would say when Dr. Callender and then beyond,
absolutely,
that had come in now, is that what we have seen now is centers of excellence. And as you said, bringing in the top folks in. Dr. Reiser already said, in our visit here that, he's going to go find folks all around. And he himself is taking on more of a role in the medical side on for patient delivery. That's in there. And you were talking about data. One of the interesting things and bringing it up is about COVID. And you have a chart here that we're taking a look at. It's the one with the charts. Tell me what we're looking at, the percentage of early deaths and how you would see this diagnostic playing in a role of this.
So here is the story. So in comes the pandemic. And what we realized is that when people presented with COVID, we stuck a swab in deep in the nose. Some people said it was almost a brain biopsy. So you think you're getting right to the infection, but it was a lung infection.
Mm-hmm.
And what that meant is that the infection is down here and you are testing up here. You got to count on some of the COVID getting up in here and being on the swab, right? So you could get a false negative.
Right.
Then we realized that there were antibody tests. Are you developing an immune response? And there are different kinds of antibodies. And we had those tests. So what we did was we started looking at the tests, the patient record, how they're feeling, what they presented with, and these antibody tests. And I said the one who was able to get service to counties all over the state of Texas. We tested samples from 2/3 of the counties, other major healthcare systems in Houston. At one point, we were doing more than 2,000 tests a day. And I said, what do you think of this? Why don't we see if Peter McCaffrey could help us take the results in Epic and we could write every single possible permutation of an answer that included the antibody test, the swab test is called PCR. And for people who had the test, some had half the test, and we would ask Epic to pick the right one. What that meant is we could do 2,500 interpretations in a day. Nobody could do this because we had the AI person, Peter, and Juan is collecting samples from all over the state of Texas and building platforms to do the testing. So we have a person on our staff. Her name is Alex Rapp. She was really the prime mover on doing the interpretations for COVID. And what that chart shows is that we are the blue line on the bottom. It says % early deaths. And what are we comparing ourselves to? The green line, that's all academic medical centers, 150 academic medical centers across the country. What about the purple line? Well, that's all hospitals in the country, 6,000 or so hospitals. And what is the red? That's the hospitals from Texas to North Dakota. How did we have fewer early deaths? It had to be the interpretive comment because it showed up in my chart. It was the only differentiator. Everybody has good doctors. These other places have great equipment. The one differentiator here was this. And I dare say somebody must have read this and said, what? I had a negative test, but they're telling me it could have been a false negative. And somebody's commenting upon my immunity and saying, I'm not immune to this. Do I have some underlying... People said maybe I shouldn't go to the family reunion, and 30 more people didn't get infected.
Right.
And therefore fewer people died. We were stunned when we looked at these data. And then we realized that we had differentiated ourselves as UTMB separately from all the other hospitals because we weren't a passive laboratory. We picked up the puzzle pieces, put the puzzle pieces together. Juan just kept bringing in the samples, and we kept doing the interpretations. And the people who received those results and the interpretations benefited from them wherever they were.
Yeah.
Just to add something to our audience on that, COVID was very interesting for us, and the diagnostic centered purpose fits that really well. And you mentioned this at the beginning. it was total confusion. Should we order an antigen testing, an antibody testing, a PCR? There are many different types of PCR, and that's where the value of understanding those tests and providing the interpretation will help a lot, because we work very close with our clinicians to say, no, should be a PCR, should be this is what it means, the antibody. If you have a positive test on the antibody, and a positive for the PCR is this. If you have negative on the antibody, but a positive on this. So that definitely just gave us a lot. And going back to what it was mentioned at the beginning, things were changing during COVID every month. And we had to very rapidly to adapt, and making sure that the whole team, and especially Dr. Laposata, was reading every single publication that it was coming on
Right.
COVID. So that's exactly the same model that we are trying to do with the different programs that the center wants to start making available to the patients. Okay, same thing that we're doing in the pharmacogenomics. We have all the genetic information. Once there is a new publication that a new gene has been associated with a new medicine, an interpretation will come on that in a real time. It's not going to be something that's going to be 2 or 3 years, because patients will benefit from that. And the cancer screening program just follow the same idea.
So right now, as we sit here, if say, let's give you another month, and you were to roll out, the diagnostic where it's open to folks, they can call, come on in
Yes.
and do this. What could you realistically do with a diagnostic now and tell folks?
Sure. I think we can safely say this. We are able to do your pharmacogenomic profiling now. So if you are interested in that, you can connect with the diagnostic center. You'll get a number.
And just so folks know, when he says that this is pharmacoding, it means like
the drug-gene interaction. Which drugs work for
right,
you?
Right.
So that's available now. We also have active interpretive services, though we are doing them the hard way, manually. You send in your lab tests, we tell you what it is. And the important part is we don't let you go until you get a diagnosis. We text you back. We ask you the next question. We set up the next lab test. So we can do that for the bleeding patient, the clotting patient. We can do that for the patient who has an autoimmune disease, so that we can sort out there maybe a dozen different autoimmune diseases where we can help sort those out. There are a number of them related to which blood samples you can get. You can get blood from that donor, but you can not get blood from the other donor. We also are building one for anemia. And if you have anemia, it's hard often to see a doctor who's a hematologist oncologist, because they're so busy with cancer. It's hard to do the hematology. That's where anemia is. So we can help with that a lot because of this, and the treatment then follows immediately. So by the spring, I think that it's fair to say that we will have, probably in an automated fashion, but it would be unknown to the consumer how we are doing it. Bleeding patient, clotting patient, autoimmune patient, patients with things like anemia. So we're going to just keep adding in these disease areas. And it will require our hiring a few more pathologists, which we're in the process of doing, who are focused on these problems. But that is the plan. And by the end of the year, September to September, maybe we'll have a dozen of these and start building the networks to connect in for all the rare diseases for experts across the country. So that's our plan. We really want to beat the 3-year plan that Seeley Smith gave us as a target. They said, okay, we'll fund you for 3 years. But at that point, let's just see if your revenue matches what we've given you every year. And we're confident about that, but we know we have to do some hard work to make it happen.
Yeah. Exciting subject. I mean, and it comes down to, I skipped one of your charts here. It really is about getting that puzzle piece here.
Yeah, absolutely. Yes.
And it all comes in together at some point, and getting the final piece of the puzzle. And this could be part of helping you solve all that. And if you folks are interested in finding out more about the diagnostic team at UTMB Health, we've put a link up in the comment section. You can link that and find out more. Or, I know he's awfully shy, but Dr. Laposata will be more than glad to take your call. No, I'm just giving you a hard time. Both of y'all this has been really fascinating to talk about here. And I'm looking forward to bringing y'all back on as we get the updates along the way
Thank
on this and how it works out. Again, the number's on the screen too, just in case you want to call and inquire about this. Maybe I would think, are you going to allow folks to come in now so you can just try to do that the pharmaceutical stuff?
Absolutely. We can do that now. We could have your blood drawn. We can have your cheeks scraped, and we could give you your results.
I mean that alone, I think, would be great. Of being, hey, if you know what meds are best or not to go with, that alone is a leap beyond what.
And you only have to do it once.
Yeah,
because it's true for you for the rest of
no
your life.
Happens,
no matter what you need down the road.
Yeah, and I see the potential. And we'll talk about this the next time y'all are on. Of going through this, being able to say, oh, you have a predisposition to this because of this gene. But then down the line, being able to combat even that you bring that predisposition down.
Yes,
in the future.
And that's something that we are very actively working and very excited on. Being able to have these ready and start, because the next product or the next program that we want to do is the cancer screening, and definitely that's something that we are very excited to have. I mean, just being able to provide the patient a different alternative and making sure that we can do something behind they actually before they get cancer is just going to be a huge difference. That we are very excited, and it's hard work coming on that, but we definitely are very excited to have that ready.
Well, it's exciting in many ways, and particularly I geeked out when I finally figured out what you were talking about on Monday, Dr. Laposata, because it took me a while, but then it started dawning on me about 20 minutes into our conversation. I went, okay, yep. And then I totally nerded, geeked out, did every research I could on this to get informed, and trust me, folks, I'm going to be going in myself to have this done.
Come on,
and we're going to do a story with that, but the cameras are going to follow me in there because this would be kind of a great way to show folks.
Terrific.
Of hey, here's it, and I can, as folks know who watch the show, I share my medical stuff all the time. I mean, forget HIPAA. No one else around here has to tell you. I'm going to tell you too. I'll show you my charts as I've done on the air here too. Thank you both for being on today. Dr. Michael Laposata and JuanDavid Garcia from our diagnostic team here at UTMB Health. Really fascinating. We could have done this show for 3 hours here. And I do appreciate you guys coming on. And Marty, I asked to just go to one shot here on it. But it is, I'll be remiss and I point out what a fun time we had over the weekend with our friends at UTMB Health and American Heart Association for the Bay Area walk. Happened at the Kemah Boardwalk. No, these UTMB staffers didn't have to walk backwards the whole route, but this was at the Kemah Boardwalk. Thousands of people came out, as you can tell here, to walk and raise money for the American Heart Association. My wife and our oldest Golden were also part of this walk as well. You can see the dogs always like to come out there. Wasn't as cold as we've had it in the past. We were worried about the crowd was going to be a little bit pushed down, and because of the weather threat that day. But outside being cloudy and a little chilly, it wasn't bad at all. And we had, like I said, you can see the line, just folks going out. This is always a fun event, always happens in November, a few weeks before Thanksgiving. So make sure you check it out next year. UTMB Health, a major sponsor of that program as well. It was great too, as you see, the Clear Creek. I don't want to get confused. Clear Brook was out there too with their squads. They're cheering on the walkers the whole time. And a bit of personal preference here is congratulations to the team from the University of Houston, Clear Lake, where my wife is a vice president there. They had a good team that showed up out there and raised a lot of money as well. And it was a fun event. You can see the video here shot by our Paul Cater-Deaton. So again, it's been great to have you two on the show today, but thanks for everyone that came out to the walk. It was really a pleasure to have you out there. We're not sure what our December program is going to be just yet. I don't think we're going to try to tell people how to cut down on their eating over the holidays. I always say, what good is that? But I may bring Dr. Samarini in to say what you can do afterwards to get your weight down, and we'll have that as well. Thank you all for joining us. I'm TJ All. So this has been Healthcare Unmasked, presented by UTMB Health.